Morning, good afternoon, good evening, wherever you are, and welcome to this session on reaching zero human deaths from dog-mediated rabies by 2030. So this is a GNN webinar. TechNet is really happy to support this webinar. You can listen to this session in French and Spanish. To do so, please click on the globe icon, which is at the bottom of your window, and select the language in which you'd like to listen to this session, so French or Spanish. And we are also introducing, we are recording this session, and we will share the recording with you by email, or you will find all the information on the TechNet website after the session. So the recording and the presentation will be made available. If you have any question during the presentation, please use the Q&A box. So the Q&A box is available at the bottom of your Zoom window, and you can ask your questions at any point in the presentation, and the panelists will answer them after the presentation during the Q&A session. I hope you will enjoy this session, and I'll give the floor to Mario. Mario, the floor is yours.
Okay, thank you so much, Alexander. And welcome everybody. I'm Mario Melgar, and we're very happy to have this webinar with you today. And just as a reminder, these webinars are open to all NITAG members. Feel free to circulate these meetings links, so more people that could be interested and can.
Mario has some technical issues on his side, connection issues.
Perhaps I can take over.
Yes, please, Bernadette.
Good afternoon, everybody. I'm Bernadette Bella. I work in the World Health Organization in the Global Program for Neglected Tropical Diseases, where rabies is embedded. And I work closely with the vaccine department on this work. I thank you for being with us today. I apologize on Mario's behalf for the bad connection. We will go through a couple of presentations that we've prepared for you to open the topic, and then we would love to have your feedback and discussion at the end of the session. This is the agenda. We will start with just an update around rabies and rabies elimination that I will give, and then followed by some of the WHO recommendations and Gavi's imminent rollout of human rabies vaccines. So rabies, as you know, is a vaccine preventable disease. And rabies also affects the most disadvantaged populations in the world, be it rural or urban. So it is an actual indicator of inequity. It affects, the highest burden is in Asia and Africa. And often children, because of their size and because of their behavior with animals, are often the victims of rabies. Our data is very limited, and it is not only not captured, but also often underreported or underdiagnosed. So in the work that we are doing as WHO and with our partners, we are striving towards 0 by 30. And I'll explain to you that in the following slide. But what we're trying to attain is reaching 0 rabies, human rabies deaths from dogs by 2030. As you know, rabies is transmitted via infectious saliva through the bites or licks on broken skin. And then it actually travels up from the location of the bite through the muscle into the nerves and then into the central nervous system. Once it reaches the brain and replicates, it then also is secreted through the salivary glands, and it is actually fatal. There have been some cases that have survived, but that's usually the patients who do survive rabies in high, economic settings where there are good ICUs, are very impaired in their yes, they have high impairment of their nervous system. So just to clarify, we have reviewed our rabies position in WHO and clarified some things, because often we get questions from countries about whether, for example, human-to-human transmission is something that happens often. Not very often. The cases we have documented are usually through transplantation or in laboratories, perhaps through mucosal route. It is a very, very rare event. There have been 1 or 2 cases documented about aerosoled viruses in labs, and very, very rarely through contact with raw meat if handlers have broken integument. We have never had any documented transmission from the consumption of milk, nor from rodent bites. And so this is really important because in many countries, rodent bites are given post-exposure prophylaxis. So as I mentioned, the 0-by-30 strategy is a strategy set out by our partners and with us, the World Health Organization, the Food and Agriculture Organization, the World Organization for Animal Health, and GARC, the Global Alliance for Rabies Control. We set out the strategy to sort of give a pathway, a roadmap for us as a global community, but also for countries to follow. We know that we need 3 pillars in combating rabies and stopping human deaths. One is immediate care of patients who have been subjected to a potentially rabid animal. The second one is really, if we want to break transmission, we really need to be vaccinating the dogs. And in many countries, we know that there are many free roaming or stray dog populations. So some amount of population management is also required. And then, of course, really crucial is awareness in the community and community engagement. What do you do to avoid bites in the first place? We can avoid bites even from rabid dogs. And then what do we do if we are bitten? So just to, you have probably all heard of the concept of One Health. I'd like to show you this graph just because it tells us why it is not only focusing on the human post-exposure treatment that is important, but really to be looking also at stopping transmission in dogs to really reach 0 transmission and sustainably reduce rabies. So if we did nothing, rabies deaths will continue to rise. That is the red line. If we introduced post-exposure prophylaxis, we will bring deaths down significantly rather quickly, but never to 0. If we put in dog vaccination campaigns, we can reduce stop rabies transmission and the deaths in humans and stop the disease propagating in dogs. Dogs are the main reservoir. We recently updated, as I mentioned, our WHO guidelines. I'm not going to go into detail, but these slides will be made available to you. And I have put all the links so that you can refer to our standard setting documents. And just to set the scene for post-exposure prophylaxis, which will be the main area we will speak about today, Category 1 is actually not an exposure. It is, for example, a licking of an animal on not broken skin. So in that case, only washing is needed. So Category 1 is actually not an exposure. It does not need any immunologicals. Category 2 is when there is a broken integument and potentially a lick from a dog. There is no blood seeping from the wound. It's a scratch. And in that case, we only need wound washing and vaccine. If a person has been provided pre-exposure prophylaxis or has received post-exposure prophylaxis in the past, then also no rabies immunoglobulins are needed. In the case of category 3, that's deep wounds, we would insist on wound washing. And wound washing doesn't mean just rinsing the wound for a few seconds. It's really about 10 to 15 minutes of wound washing with soap and water, and then followed by vaccine and when needed, immunoglobulins. I won't expect you to read this decision tree, but we have, and you can download these from our website. We will have broken down trees, more visible images for you to download in the next weeks from our website. And this helps the clinicians actually make the best decision on whether, for example, vaccine is needed or immunoglobulins are needed. So this is a resource that could be used in the clinical settings that you can download from WHO. So quickly, just to come back to the WHO's position that was set in 2018. Not many countries have actually updated or aligned their policies with WHO's policy. And this is why we have you here, because as we move forward and you listen through the other presenters, Gavi will be rolling out rabies vaccines. And we will be recommending to countries as much as possible to roll out with a cost-effective, shortened schedule and intradermal administration of rabies vaccines. So intradermal will mean 0.1 milliliters on 2 sides, so 0.2 per patient. Intramuscular would be the entire vial, be it 0.5 or 1 milliliter. We have about 4 pre-qualified vaccines, and the open vial policy is the same across the vaccines. If you are fractionating, that the vial must be discarded after 6 to 8 hours. So we have had some reactions from countries saying that intradermal is rather complicated, but from others who have been able to roll out intradermal, it is quite a feasible administration route. So just to update you quickly, and you'll hear more from Nassim on this, in 2018, we looked at a lot of data, and we have really tried to prioritize the shortened schedule of 0, 3, 7, ID 2 sites, so 0.1, 0.1, as the preferred schedule, but of course the other schedules are also valid. So our ask to you today as the NITAGs in your countries is to be looking and aligning perhaps your policies, if they are not aligned already, to be looking at the data and updating these as you go. As you know, RIG is not often available, is also a very expensive commodity. If it is given, it should be given within the first 7 days following vaccine. Otherwise, it would get in the way of the immune response after the vaccine. So rabies immunoglobulins, as I said, is not recommended if some stage in your life you have received vaccine and you do not need immunoglobulins. However, if you are exposed to a rabid animal, then vaccine is indicated. So RIG is the passive protection. It must be administered deeply in and around the wounds. We do not recommend any more. If you have any leftover rig from the administration of it, we do not recommend putting it into the muscle. It does not have, it has very limited effect if given intramuscularly. So the dosages are noted here. And we do have 2 monoclonal products that are available on the international market, produced in India. I also would like to highlight the shortened schedules around pre-exposure prophylaxis. We recommend pre-exposure prophylaxis in high-risk individuals, mostly used in travelers or individuals at occupational risk. And in fact, only when communities are really remote in high endemic settings and limited access to post-exposure would we recommend pre-exposure prophylaxis. Again, in this case, we have reduced the schedule, and the data is looking like we can probably reduce it even further, that pre-exposure on day 0 and day 7 booster, and that is enough, with a 2-site ID on day 0 and 7 and 1-site IM on day 0 and day 7. We have also published to support countries that are potentially going to start rolling out rabies in their public health system, a guide on the steps on decision making and how to construct a national plan, how to go about micro-planning at the health facility levels, what training and service is needed, what training is needed in order to provide the services at the level that it will be provided at. Will it be at district level or at a provincial level, or perhaps even primary healthcare level? And of course, the need for demand generation, the communication and social mobilization of communities. And of course, it will also cover some of the tools in order to have monitoring evaluation. And with that, I will be happy to answer to any questions later on, but with that, I pass on to my colleague, Dr. Naseem Salahuddin from Karachi. So, Naseem, you have the floor.
Thank you, Bernadette. My name is Naseem Salahuddin. I'm from the Indus Hospital and Health Network in Karachi, Pakistan. Bernadette, thank you for the introduction and for the invitation to speak on this very important subject from Pakistan's perspective. Just to give you an oversight of where we are, and this is the map of Pakistan. We have 4 provinces and 2 administrative units with a population of 240 million. Sindh province is here is the southernmost province in Pakistan. I've magnified the Sindh province. It consists of 7 divisions and has a population of nearly 56 million. Karachi is right here by the ocean and has a population of 20 million. I live over here in Karachi. Now, Pakistan is a low middle income country with weak healthcare infrastructure and insufficient human health resources. There are presumably 3 million stray dogs that inflict over 1 million bites annually. Sindh province alone reported 200,000 bites in the first 10 months of 2023. But this data is taken from newspaper reports and is not necessarily verifiable. However, I can vouch for these numbers from the dedicated Rabies Prevention and Training Center under my care at the Indus Hospital, which provides free care. You can see the rising trajectory of dog bites is quite apparent. Only in 2023, we recorded over 13,000 new dog bite victims who received PEP, and half of them were severe category 3 wounds. We collated and analyzed data over 11 years of 150 rabies patients reported in 2 major centers of Karachi. They came from distances as far away as 500 kilometers and destined to die. None had received PEP. There are a lot of challenges in LMICs, including Pakistan. First of which is lack of community awareness. People still don't report dog bites. Rather, they use domestic remedies, household remedies like salt and pepper and oil and so on, which worsens the situation. Secondly, there is very poor knowledge, attitude, and practices amongst doctors and paramedics. Thirdly, there is inadequate understanding of cell culture vaccines and rig applications. Then there are frequent outages of vaccines and rig, which further complicates the attention given to the patient. And finally, would you believe it? Many institutions believe that PEP is unaffordable, and they do not even keep a supply of the required biologicals, thinking that they just won't be able to afford it. So, sorry, we have made a plan of action at the Indus Hospital, in which we raise awareness throughout the year through the print and electronic media, through pamphlets. Then we train healthcare workers for wound wash, risk assessment, and wound severity. We try to improve the understanding of vaccine and rig. And most of all, we propagate the intradermal PEP, which has just been advised in 2018. And something that we cannot do on our own in the domain of the government is to advocate for uninterrupted vaccine and rig supply. Confusion reigns among healthcare workers about PEP. They're confused about what brands. There's so many brands in the market, all imported. They don't know which volume is applicable. Is it the 0.5 ml or the 1 ml? Should the vaccine be pre-qualified, or could they use a non-pre-qualified vaccine? Then the evolving IM versus ID schedules, which one should they choose? The packages often, in the package insert often writes for IM use, and yet we encourage them to use it ID. How to store the reconstituted vaccine, interchangeability of brand and the route of administration, what to do in a case of re-exposure. So all these things are really pretty muddled. Secondly, in the rabies immunoglobulin, we do know that human rabies immunoglobulin is unaffordable in our part of the world. However, there are physicians are worried that equine rabies immunoglobulin is fraught with adverse events, and worst of which could be anaphylaxis. So they're afraid to use rig. Nerve tissue vaccine was declared obsolete in 1980, but remained in Pakistan till 2015. But the memories of the 14 injections into the belly have still persisted, and grandmothers and mothers still tell their children that if you get bitten by a dog, you're going to get 14 injections into your belly. And so children sometimes don't even report their wounds. Now, cell culture vaccines, when introduced, were to be given intramuscularly, but to give 4 whole ampules for each dog bite victim in a high footfall clinic in a rabies endemic country is absolutely untenable and unsustainable because of the enormous cost. So in 1984, the Thai Red Cross intradermal vaccination regimen was approved, and which was given over 5 visits up to day 90. That means the patient had to come back on the 3 months after the bite or after the first dose. And that was in practice for a while. Then in 2006, the TRC updated to 4 visits and reduced it to day 0, 3, 7, and 28. Still, 1 month later, the person had to return for an additional dose. But after the WHO position paper in 2018, the IPC 1-week schedule reduced it to 3 visits on day 3 and 7, and also reduced the amount of vaccine to be used. So medical colleges do not teach rabies prevention systematically with updated changes. Hence, there is so much confusion amongst healthcare workers, and there is much misplaced apprehension and mismanagement of PEP. I had the privilege of sitting in the working group of the SAGE on rabies vaccine and immunoglobulins from 2016 through 2017. And there were 8 meetings which happened virtually and 2 in person throughout the year. The resulting WHO position paper was published in 2018. And what they advocated was the still shorter 2-site 1-week ID regimen. Secondly, the calculated rig should be infiltrated into the wound only, and the remaining not into a muscle, as we were previously taught. So the remaining vaccine should be saved for the next patient. Therefore, more people could be treated with rig left over from the previous patient. Of course, you have to maintain the sterility of the rig and the vaccine. Other recommendations were made for pre-exposure prophylaxis, repeat bites, and so on, and were all there in the position paper, but this is not the place to discuss in more in-depth. Subsequently, many papers were published in peer-reviewed journals. We did our own homework at the Indus, and our work was published in the WHO Bulletin in 2021. And what we did was we compared vaccine consumption and cost between 2017, that is pre-position paper, and this was the historical controls, against the 2018 post-position paper. And this is what we found. In 2018, we treated 500 more patients and saved 140 ampules of vaccine. We treated nearly 200 more patients with rig and saved 436 ampules of rig. And the total savings of $4,000 maybe is a significant financial benefit for the hospital, considering the high volume of patients we treat annually. So our findings convinced us that the 1-week 2-site ID regimen saves vaccine and cost without compromising patients' safety. Secondly, deleting the day 28 dose saves patient anxiety, cost, travel and accommodation, and the daily wages, because they have to come from distant places. And last but not least important is that it frees up space in the center's waiting area, and that is substantial because we have a very large turnover. Our plans for 2024, we have formed a working group of experts and have written up a publication for distribution of comprehensive national guidelines. This is just about on the anvil and will be ready for distribution. And it stresses, among other things, it stresses the 1-week PEP. We would like to have more PEP centers for hard-to-reach populations and ensure accessibility to free vaccine and rig through the government. We pass our expertise on to other healthcare workers with training workshops where they learn to interview, examine the wounds, and make decisions. And our thrust is on wound wash, thorough wound wash, rig infiltration, and correctly injected ID vaccine. They must learn how to raise the bubble, without which the vaccine would fail, and to counsel the patient and ensure their follow-up. We identified 29 healthcare facilities in Sindh that need training. 15 are up and running, and we have more work cut out for us. We have signed an MOU with the Sindh Health Ministry with our hospital, where they have agreed to help us form more PEP training centers across the country. The EPI was launched in 1978 and NITAG in 2014 under the Ministry of National Health Services Regulation and Coordination. We've done a lot of work for public awareness and education. We celebrate World Rabies Day every year, and in between the years through pamphlets written in the electronic press. In 2017, we ran a pilot project on One Health, where mass dog vaccination and dog population control was done for until 2022. We completed the project successfully. We have been working as individuals, private hospitals, NGOs, civil society. What we should really have is a top-down approach through the regional organization, WHO country representative, the MOH, and devolve down to the districts. Strategic planning should be to organize PEP centers countrywide, build capacity, enhance ID training with a 1-week regimen, and provide quality rabies vaccine at no or low cost. Many more challenges remain related to the human and animal surveillance, to identify high-risk populations, vaccine forecasting, efficient use of rabies PEP, and collaboration with animal health sector. We need more public health education, mass dog vaccination, dog population control, updated human PEP regimens, and it is only then that we can succeed in zero human deaths from rabid dogs. Thank you very much.
Thank you very much, Naseem. I'm sorry, the slides are flipping without my control. Thank you very much for that very informative session. We will have opportunity to ask you more questions at the end after Simba provides his presentation. Over to you, Simba.
Thank you very much, Bernadette, and hello, everyone. So my name is Simbarashi Mabaya. I'm with the vaccine programs team at Gavi, and at the moment I'm leading the design of the Gavi programs for rabies post-exposure prophylaxis in humans, as well as the hepatitis B birth dose vaccine program. Next slide, Bernadette. So some of you, I think, or most of us here will remember that in 2018, the Gavi board approved a program for human rabies post-exposure prophylaxis, which was supposed to start in 2021, alongside with other vaccines, including the hepatitis B birth dose vaccine. And the design and launch of these programs was delayed in 2021 due to the COVID-19 pandemic, and we obtained a green light to proceed with the design and launch in May of 2023. And that is what we've been doing with the support of a group coordination team that comprises members from different Gavi Alliance partners. So that's what I'll be talking about this afternoon. I think most of us being NITAG members already have a good understanding of what Gavi is and how Gavi works. But I'll just quickly go through that again for everyone to remind everyone. Then I'll talk specifically about the support that we are going to provide for rabies vaccination. So Gavi is a public-private partnership with those types of organizations on the screen, including UN agencies, governments from implementing countries, as well as donor governments, civil society, industry, academia, and also private foundations like the Gates Foundation, and also including also the World Bank. So it really includes everyone is part of this broad alliance. Next slide. So over the years, Gavi now provides vaccines for 20 different infectious diseases using 46 different product presentations from the first strategic period of Gavi in 2001, 2005, that we call Gavi 1.0, where there was vaccines for 6 diseases, up to now in Gavi 5.1, where we have vaccines for 20 diseases, and there are some more vaccines which are going to come as part of the Gavi vaccine investment strategy for 2024, which will be implemented in 2026 to 2030, depending on the availability of the specific vaccine products and depending on which vaccine from that list are recommended by the board in June 2024. Next slide. So Gavi supports countries mainly through three financing levers: support for health system strengthening. So this is support that is for things like the enhancing demand, enhancing coverage in countries, helping with data systems, helping with the health workforce and other things that are related to the health system strengthening. Then the Gavi also provides support through vaccine support. This is procurement of the actual vaccine doses, as well as technical assistance to help countries to improve the quality of their programs. Next slide. This may be known to most of us, but I'll just quickly again go over it. So not all countries are eligible for Gavi support, and countries are eligible for Gavi support based on their gross national income. So currently, the countries are defined by the World Bank as low income if their gross national income is less than 1,085 per capita. So all those countries with their gross national income below 1,085 US dollars per capita are classified as low-income countries, and they receive Gavi support. But to enable sustainability, countries also contribute to the cost of the vaccines that Gavi provides. So all those countries classified as low income provides supports 20 cents US cents per dose that is procured by Gavi. So they contribute to the cost of the vaccine at 20 cents per dose, regardless of the price of the vaccine. But as the country's economy becomes better, they also transition to previous slide, please. Yes. So as the country's economies become better and their GNI per capita increases, they move then from the initial self-financing phase where they contribute 20 cents and they begin to contribute more and more gradually in the preparatory transition phase, up to the time when they get to a GNI per capita of 1,730. This is a Gavi threshold, and then they can also co-finance at least 35% of their vaccines. After that time, then they move to the accelerated transition phase, which is for 8 years, where they again progressively increase their contribution to the vaccine support until they graduate out of Gavi support. At the moment, Gavi is really looking at the strategy for supporting middle-income countries, which is going to come. But at the moment, particularly for the rabies vaccine, we are not providing support for middle-income countries. Next slide. So this is just a list of all the Gavi eligible countries and the transition phase that they are in. There's a link at the bottom of the slide to the Gavi website where you can get more details on the co-financing policy as well as country eligibility. Next slide. So I'm going to talk briefly about the application process, which I think most of us are already aware of. So I'll go over this quickly before I start to talk about the specifics of the support that we are going to provide. So this is a link to the Gavi website. We will see all the different types of documents that we have there, which will help countries to provide, to request for support from Gavi. But of interest to us at this moment is the third document, the vaccine funding guidelines. So this is the document that explains to the countries what they need to include in the applications for us to think that this is an application of good quality that Gavi can support. And I think it says we are also discussing with our within our NITAGs, also engaging the Minister of Health. These are some of the components that we need to discuss and to ensure that how we can support our countries to be able to successfully include those in the applications and implement them. So applications to Gavi are submitted through the country portal. This is an online portal where applications are submitted. Then they are pre-screened by us in the Gavi Secretariat as well as other partners in the alliance. We provide initial comments. Then we send back to the countries. The countries can act on those. After that, then the applications are submitted to the Independent Review Committee. I will talk about that committee on the next slide. And then the committee can then make a recommendation whether to fund the application, and then they can approve the application, but they make a recommendation to fund the application, but also highlight some issues that will need to be addressed. Then those will be addressed together with the countries. That's the last step, the issue resolution. Next slide. So the Independent Review Committee, most of us here might be aware of it already, but this is a group of independent experts The idea is to guarantee the integrity of the process in a way that is open and transparent. So these are people who are not Gavi employees, and their only link with Gavi is through this committee. So they look at the request for new funding, then they recommend whether we should fund it or not. It's people from diverse backgrounds, vaccinologists, public health, epidemiology, from health financing, from supply chain, or from all the different aspects of the vaccine programs. And this pool at the moment really is made up of 99 members from across different continents. 38% of the country members are actually from the African continent. So going forward, Gavi is going to have three windows where countries can submit applications every year. So this year, the three windows, the first two actually have gone, the one in January and the one in April. But for these vaccines, which were paused in 2021, we've been allowed to have an ad hoc special window, which will be in July 15th, just to allow these specific vaccines, countries to submit applications for these specific vaccines. And after that, there will be another subsequent window this year on the 23rd of September. But in subsequent years, so from 2025 going onwards, then there will still be just three windows in January, in April, and in September, through which countries can submit their applications. Next slide. So I'm going to talk a little bit about the full support that we are going to provide specific for the rabies vaccine program. Next slide. So again, as I said, that the most important document for this is the vaccine funding guidelines. And when the vaccine funding guidelines are published, you're going to see there will be a chapter on human rabies post-exposure prophylaxis, and that's where you will get all the details of what we would like to see as the key considerations in the country applications. Next slide. So in overview is that the support that Gavi is going to provide for rabies is incremental. So it acknowledges that countries already have got rabies vaccine programs in different scales. And this support is really supposed to be in addition to what the countries are already doing. So we'll ask countries to ensure that in their applications that whatever they've been supporting, whatever they've been providing, say for the procurement of the rabies vaccine, should not be reduced or stopped, but should be at least maintained or even increased. Then whatever Gavi is going to provide is going to be on top of that. So this is actually very important. Again, if you remember that, as I said, that I think the basis of the Gavi model is really to ensure the sustainability of the support of the programs. So to enhance this sustainability, we need not displace domestic funding that has already been committed for these programs, but to add on so that we can be able to increase coverage. So Gavi is going to procure the vaccines for post-exposure prophylaxis. No vaccines for pre-exposure prophylaxis at the moment, but you will see that in the guidelines, we're going to talk about opportunistic use of PrEP. So if the vaccine, the country is using intradermal vaccination, the vial has been opened, and there are residual vaccines which are going to be thrown away after the 8 hours. So the country can then use those vaccines maybe to immunize, if they're to vaccinate, say, their veterinary workers around the district, then they can also be able to access that vaccine. And we are not going to provide any support at the moment for the rabies immunoglobulin. We are going to provide vaccine introduction grants, which are funding to support activities for introduction of the vaccines. So from the previous presentation, this can be used to address some of the challenges that the previous speaker spoke about, like training healthcare workers in the intradermal vaccination. And Gavi also has other funds, streams for funds, and countries can still use those countries. I think those funds within their existing ceilings, also after accounting for other programmatic priorities. Next slide. So I'm going to talk quickly through what we think are the key considerations that countries should include in their applications. And this also, if these are included and well addressed, then it will also increase the chances of the country application being recommended for funding by the IRC. we'll need countries to show that there's been a decision made to introduce this vaccine. So maybe later from the Minister of Health or a delegated authority, minutes of the NITAG meeting that recommended this vaccine, as well as the Interagency Coordination Committee. My colleagues that work on receiving these applications have asked me to emphasize the need of having NITAG decisions. I think some of the applications that are coming now, they do not have these NITAG decisions, and they're supposed to come later, but they do not come. So they've asked me to emphasize this, that they really need to have these NITAG decisions for them to be able to proceed. So unlike the other vaccines that Gavi has been supporting, the target age group for rabies is a little bit wider. It includes everyone of every age, and it's really post-exposure. It's not a routine vaccine or a campaign vaccine like the ones that we normally support. So there's really on this need to be able to think through how we are going to define our targets, how we are going to estimate the doses. There are some publications already for the different countries on this. So we need to look at that, look at the data that we have in the countries, look at our previous consumptions, so that the number of doses that we are going to request from Gavi are not so much that we will not be able to use them, and we're going to have a lot of them expiring, or we are requesting so few so that we will just end up with stockouts after a few months. So Bernadette spoke about intradermal and intramuscular vaccination schedules. So the Gavi support is going to be aligned with what WHO recommends, which is both IM and ID vaccination. However, we are really encourage countries to move towards intradermal vaccination. This is cheaper for everyone. It's also cheaper even for patients, so that they can come to the facilities, but they're going to have fewer visits than if they go for IM vaccination. It uses a smaller volume of vaccine. It also saves time even for the healthcare workers. So I think intradermal vaccination is good for everyone, and we need to encourage our countries to make decisions for this transition, and it's what also can be used for the vaccine introduction grants to train health workers to transit to be able to offer to deliver vaccines through the intradermal route. Next slide.
Imba?
I
apologize, this is Alex. Can you please speak a bit more slowly for the interpreters? Thank you very much in advance.
All right. Thanks, Alex. Apologies for that. So we also ask countries to demonstrate in their applications that there is comprehensive rabies control within their countries. So to demonstrate that, we need the countries to have a national rabies control strategic plan. So for their initial applications, we are not going to ask for this to be included. If it's available, then it can be included as an attachment to the application. But in subsequent multi-year applications, we will need the countries to include a national rabies control strategic plan, and there are other partners who are supporting countries to be able to develop these strategic plans, particularly the United Against Rabies Group, so World Organization for Animal Health, WHO, and FAO. There's some support that's available through them to be able to develop these comprehensive national strategic plans. So I would encourage us to reach out to them so that we are able to provide this at least for our next multi-year applications. So the rabies vaccine is unique, again, as I said, quite different from what we've been doing, and it's really something that's going to be delivered in the context of our primary health care. So people would come to the facility because of the wound, maybe primarily, not because of the vaccine. So we really need to think about how to make that link between the primary health care, between this wound management, and also the vaccination, so that people, the healthcare workers, are aware that this vaccine is available and they can use it, but also even for the patients themselves to be aware, so that they can be able to demand this vaccine when they come for the management of their wounds. We know that in most places, the surveillance for rabies is not in very good shape, and something that we want to encourage countries to strengthen as part of their vaccine programs. There's minimum data elements, I think, which are defined by UAR, by WHO, World Organization for Animal Health, and FAO for monitoring and evaluation of national rabies control programs. So there is a link that is on the slide. I think I would encourage us to look at that and see what they're asking for, and then reach out to Bernadette for any clarification. I've spoken about this, but let me re-emphasize that Gavi support is incremental. It adds to what the country has already been is already investing. So we are going to require countries to say in the applications that we have been investing so much for the rabies program, and we are going to maintain that and to reach our coverage targets. In addition to what we are providing, we need so much from Gavi. The idea being that we don't want to displace any domestic funding in the spirit of sustainability, as I've said. We also need countries to think through equity. As we've heard, there's all these differences to access of the vaccine between urban and rural, and sometimes between men and women, depending on the different contexts. So this is one of the key considerations that we want the applications to look at. How this is going to be ensuring that there are no geographical areas that are left out, but also other gender considerations, age considerations. We know that children are often more affected by rabies, maybe because of their size. They play with dogs and they're the small body size, so that because of that, then they tend to be bitten by dogs more. So we need to ensure in our programming that we ensure equal access for older people, but also for children in our programs. So over to my last slide. So what's next? So as I said, that the program will be launched on the 12th of June, 2024. And by launch from our end, we mean that that's the day when the vaccine funding guidelines will be published, and countries will have the first opportunity to submit the applications by the 15th of July. So we realized that that's really quite a short period of time, just about 1 month. And for those countries that are really interested in submitting their applications by July, we are already, if they express their interest to us, then we can already start to provide them support even before the launch of the program, so that they can be able to prepare to be able to submit by the 15th of July. If they miss the 15th of July window, the subsequent window for the year is going to be in September. Thereafter, there will be the January 2025 window and the other 2 windows coming up again 2025. We are going to provide technical assistance to support countries in their development of the applications, and we are going to do this through consultants. If a country needs a consultant to help them with the development of the applications, we'll be able to provide that support. And I think that the unique part about the rabies vaccine is that it doesn't always, countries sit within EPI, some in zoonosis, some in NTDs, some even in animal health. And we would really encourage countries at the country level to coordinate through all the different relevant ministries, and to express their interest through their respective Gavi senior country manager. So thank you very much. That's my presentation. And at the bottom of this slide is the link where you can, if you go into that link, you can get more details on all the different Gavi fundings and all the Gavi processes for accessing funding. Thank you very much, and happy to take any questions. Thanks.
Thank you, Simba. Thank you, Nasima. Thank you, Bernadette, for these very comprehensive presentations. And we have time for questions, and we have a couple of questions in our Q&A window. So the first question is for Bernadette. It's from Maria, and she's asking your opinion, Bernadette. What is the time limit for how long immunoglobulin is indicated for exposure? UK guidelines says up to 1 year after exposures, while WHO has no limit.
So immunoglobulin shouldn't be given after a patient is vaccinated. because it actually it becomes counterproductive to the immune response for the vaccine. So we always say provide the rig between day 0 and 7 after the vaccine has been given. Now, if the vaccine wasn't given immediately, it's the same timing. You can always give the rig within that 7-day window after the first injection of vaccine. I hope that clarifies. But any person who has had rig any time, has had a vaccine, a rabies vaccine, any time in their lives, will not need rig if they have been exposed to a dog bite following this sort of pre-exposure or a full post-exposure vaccination.
So if I understand correctly, if it was the case that the patient hadn't started their vaccination yet, they could start immunoglobulin up to several months, even after they've been bitten.
Yeah, the only problem with that is that the wound is probably closed by then.
Yeah,
so
it makes more sense. Yeah.
But Nassim is the better person to answer this, as she's really a clinician on an everyday basis.
Yes, thank you. Ideally, one should get the rig and the vaccine on the same day. But if you don't have the rig at that time, sometimes the patient comes in the middle of the night and the doctor physician on call does not know how to inject, how to do the infiltration, then they may call them the next day or the next day, but not beyond 7 days, because as Dr. Bernadette just said, it will only retard the development of natural antibodies from the vaccine. So try and get it on the same day or at least the next day, but not beyond 7 days, yes. We try to give it in our clinic on the same day, but the patient comes at night, then we tell them, we'll give you the vaccine, but come back tomorrow morning, and then we'll infiltrate the rig.
I will have a follow-up question on this because a lot of places won't have a immunoglobulin. So what would be the alternative for those places?
If it's a really serious wound, such as on the head and neck or face or in the axilla or very close to a nerve, then they really should get it. But if not, okay, in answer to your question, it is really, despite all your efforts, you don't have it, then you can give them the 4-site double dose, 4-site meaning on the infrascapular area and and in the over the deltoid, intradermal, and just hope for the best. But of course, I would emphasize washing the wound very thoroughly as much as possible. But then, we've seen patients lost to rabies if the rig is not given and the wound has been on the face, on the, in a sensitive part where the area is very highly innervated. So you just must have that at hand. I know it's not every place has it available, but, do the best you can.
So
Or sorry, I was going to say, maybe you should prioritize in order to say what a rig you do have. You can prioritize with very severe wounds on the head, neck, and face, hands. But if it's on the lower extremities, you might just get by with using the intradermal, or sometimes we might give a double dose of intramuscular. You're doing all you can to raise the antibodies as much as possible, as early as possible.
So
yes.
In some countries, what has happened, first of all, we provide on our position paper a way of sort of conducting a risk assessment and providing the highest priority cases with rig. If you have a full waiting room, then you can sort of prioritize who gets it, as Nassim just said. And then perhaps that there is a stock held, maybe not in every district hospital or depending on how big the country is, but then to have maybe a stock at a provincial level so that patients can actually acquire it either by going there or that the rig is sent to the place where the PEP is being conducted.
I just add a little bit more. Rig is made from either equine or human serum. But in the very near future, actually, this is being done in some part in India, is to use a cocktail of monoclonal antibody. And that would be more feasible, doable to replace RIG. I mean, it would work just the same way as the RIG would, with the same timing and so on, but it would be available in larger quantities. Right now, it would be very expensive, but in time to come, I'm sure the prices will reduce. But, you know, that's for the near future.
Hopefully. Thanks. And we have another question. I'm going to skip that one for a while, just because the last question we have, at least in the Q&A, is about RIG, actually. And it asks, I don't know, it's not the last one, but it's a follow-up. It's another question. And it's a question for Simba. So what's the rationale for Gavi not to provide actually RIG?
Yeah, thanks very much for that question. I'd actually attempted to answer it. I've posted also in the chat the Gavi investment case, which explains what everything that went into the decision to fund the rabies vaccine program. But in short, RIG was considered as part of what Gavi could invest in, but it was deprioritized because the cost was quite high. And also looking at the incremental impact in addition to PEP, the incremental impact was limited. So always knowing that resources are always limited and there's always need to make decisions for prioritization, it was then agreed that we will prioritize PEP, at least at the moment, over RIG. Thanks.
So can I just add something, Mario, please?
Sure.
So, in many countries in Africa, only about 2% of category 3 bites get RIG at this point. If we can already get vaccine into the patient as quickly as possible following a bite, the evidence that we have reviewed shows wound washing, as Nassim emphasized, wound washing for 15 minutes, soap and water, that's it. Soap and water washes out as much virus as possible, and if we can give the vaccine as soon as possible, we can save many lives. So I guess, Simba, in the application guideline, it will be requested that countries provide some type of description of what they're doing currently with regard to RIG, and perhaps in the future have some plan of having sort of a matching stockpile to go for the very severe cases. Right, Simba?
Absolutely. So I think for now, the requirement is for the countries just to describe what they are doing for RIG and any plans that they have to increase the access for RIG through other potential funding streams. But also we're going to ask countries to explain how they are going to strengthen integrated bite case management, because I think that this is really important. In addition, because we realize that our support is going to be most effective if all the other aspects are taken care of. But at the moment, we are unable to provide RIG, and we really want to scale up integrated bite case management, including PEP. Thanks.
Okay, so another question is from Nikita. She asks about categorization. And she asks if category 3 is severe exposure, for example, deep wounds, and category 2 is the more superficial wounds without blood and just scratches. Well, what if there's a drop of blood after receiving superficial scratch? Do you classify it as category 2 or 3 if the animal is behaving relatively normally?
Nassim,
Who wants to jump on that?
Yes, there is often a confusion between category 2 and 3. Yes, my healthcare workers some will say, no, this is a little bit deeper, it should be called category 3, and some might say no. But again, you don't want to waste RIG. So you will have to make a considered opinion on that. You should make sure that there are not multiple wounds. Sometimes children don't tell you that they've been bitten on the back, on the buttock, or anywhere else. But in a child, they should be properly examined for any multiple bites. And sometimes patients themselves ignore a bite on a limb and do not tell you about it, and you see it on the face, on the arm. But all these, if you have so many bites, multiple bites, deep bites, then they all should be infiltrated with rig. I'm sorry, but it sounds, but I'm very didactic about it. We've lost patients who have not been given rig, who've been given a vaccine on day 0, 3, 7, 14, but they come and they were never given rig despite deep wounds. And we've seen them come back to us 4, 6 weeks later with full-blown rabies. So it really, I think we have to work hard at that. I know you're not going to provide it through Gavi, but maybe just I'm hoping that when we get the monoclonal antibodies, can be produced on a larger scale and more people will be able to have access to it. I'm just hoping. I've seen far too many deaths on rabies with rabies that I can, safely say that they don't need rig or you can bypass rig. No, you really must make an attempt for it.
Thank you.
Thanks. We got a couple of questions in French. I'm trying to translate them. Should we vaccinate contact cases? And what's the time for rescue in a rabies case? I don't know if I'm translating that correctly.
So rabies is transmitted by bites, right? So a human touching a human is not going to transmit rabies. So contact tracing in the sense of following in a community and doing an assessment whether other people were bitten, and you identify more people bitten by that same rabid dog or other rabid dogs, then yes, that would be valid. But a human touching a human, and Nasim can speak more to this, when the child is dying from rabies, there's no harm in holding that child's hand and giving them a little bit of love and lost, some care in their last moments. So Nasim, anything to add?
No, I've seen dozens of rabies cases and it is heartbreaking, believe me. I just reach out to that child or that adult and nobody's ever bitten me. Person to person rabies has never been documented, except of course, you talk about the transplant organs, but that's a totally different issue. But it really doesn't happen. The patient with rabies is so distressed. They're confused. And I think it's a wrong impression people have been given that they go out and bite you and they, shout or scream in a barking sound. I've never seen that. They just confused. They say, please save me, mujhe bachao, or just save me. I'll do anything if you can save my child. But I've never been bitten, and none of my colleagues or my healthcare workers has ever been bitten by a patient with potential or full-blown rabies. I can vouch for that.
Thank you.
Following up on that question, sometimes healthcare workers want post-exposure prophylaxis when they have taken care of patients with rabies. If they did, especially if they did some procedures like a central line or lumbar puncture, would there be any indication on that? I guess maybe that's one of the contacts that they're asking about.
Well, first of all, a patient with rabies should not be handled with any kind of a procedure. No central lines, no intubation, nothing of the sort. I mean, a simple cannula to rehydrate them. But, it is rabies is spread through the saliva. I've seen at least 1 or 2 cases who have been intubated, and I think that was a big mistake, because that's where you can be exposed because the saliva might fly out or then they start suctioning. I think that is definitely a no-no. You should not intubate or suction a patient with rabies. So, I mean, that is a separate discussion, and such a healthcare worker definitely deserves prophylaxis. But other than that, as I told you, I've seen dozens of rabies cases, but I've never seen the indication for getting myself vaccinated.
So just to point you to, we have put some WHO resources into the question and answers just for people to be able to copy them and take them. But Nassim and other clinicians have helped us put together also some standard operating procedures with regard to palliative care, which goes beyond this conference, but just that you are aware that there is this in our resources.
Thanks. We have another question. It's how to deal with the lack of awareness of population despite PEP is free of charge and available in healthcare structures.
It
So,
should. Yeah.
Go ahead, Nassim.
I was going to say that people who travel in cars will never get bitten. At least over here, it is the people who, pedestrians, garbage pickers, who are, randomly moving around on the street, they're the ones who get bitten. So you can't give them pre-exposure prophylaxis to everyone, but they have to be saved from bites.
So one program that we are working on and we work with many partners is really child programs and community awareness programs on bite prevention within schools or within communities, and then sort of trying to identify when a dog is behaving oddly and how to avoid contact with those animals. So we find this problem across the world, that there's a lack of awareness even among healthcare workers around this. So there's still a lot to be done. I think working, finding your own avenues within the countries to say, either insert this into curricula. There are a lot of child programs with health messaging. This could be something children also like to hear about, how to behave with animals. They like animals, so you have a good reception, and those children take the messages home. So that's a really good avenue, but still a lot to be done, and I guess case by case in countries. So I know Philippines, for example, or South Africa have inserted rabies and bite prevention into the school programs, for example.
I think we should use every single means of raising awareness, whether it is going street to street or on print media or electronic media. I think we should even go internationally to raise this issue. Locally, yes, it is there, but when you raise it as an international issue, it will have more effect. So I would really emphasize that a lot, awareness.
Thanks. And I have a question about dog vaccination. Maybe Bernadette, you can expand on how is that in most of the countries, and I'm guessing that Gavi is going to provide a human vaccine, but I don't know if animal vaccines are also provided.
No, the dog vaccination program for dogs would not go under Gavi, but we are really encouraging countries through the vaccine funding guideline, as they put in their applications to describe what they will be doing in the longer term with regard to dog rabies control. So they will have to mention that in their application. There is a vaccine support program through WOA, the World Organization for Animal Health. I know that in PAHO, in the Americas, there's also an opportunity to go through pooled procurement via the PAHO fund, for example. So and then some of the veterinary services are not able to scale up dog rabies vaccination programs. So often we have to work with civil society for this. And in countries where there are a lot of roaming dogs, then the vaccination campaigns is not conducted. The owner comes to the veterinary clinic. We actually have to actively go out to the communities to vaccinate. In some cases, like in Tanzania, there is a one-point vaccination place where people come with their dogs on a scheduled date after the community is made aware of that date. Or in places like South Africa, it's door to door, where the communities are told when the vaccinator will come through, and then the dogs are vaccinated free of charge. This is a public good disease in a sense. Dogs are not seen to be economically providing anything. So often veterinary services are not prioritizing rabies. I mean, the Americas have a great example that, your countries came together in a joint strategy using vaccination of dogs as the key to reducing or eliminating rabies. That is what we'd like to do. It's our proof of concept. But most countries haven't yet been able to scale up the dog vaccination side. We are doing our best to support countries to do so.
Thank you. We have again a question about contact with a case of human rabies. I don't know, Nassim, if you could just follow up again on the contact with a human case of rabies. There's no need for vaccination.
As I said earlier, there has been no known case of person-to-person transmission. But however, if somebody has, a patient with rabies, their saliva has gone into the mucosa by, spitting or coughing or something, then I think that person deserves PEP, post-exposure prophylaxis. But generally, these patients are sedated. If you sedate them, they're quiet. So I think if the person is apprehensive about it, I don't argue with them, especially a family member who says that the children had been playing together, or some possibility of transmission. But again, this has never happened in the past, to my information.
Thanks.
So the intradermal vaccination route provides you with an opportunity to provide with one vial multiple people. And Gavi will accept that any leftover vaccine in the vials at the end of the day, for example, can be used for pre-exposure prophylaxis, either for family members or for hospital staff or healthcare staff.
Yeah, and I skipped a question, but I think it was already answered. And if a person is exposed to a dog bite in, say, Pakistan, received no post-exposure prophylaxis, then comes after 1 year, should the rig be given?
The first question I ask such a patient is, where is the dog? If the dog is alive and well after 10 days, then
1 year.
that dog is not rabid, and so, you're okay. But if the dog escaped or was killed or is dead, or after 1 year, well, it's hard to say. And the incubation period is generally, on the average, about 6 weeks. It could be shorter, it could be a bit longer. We've seen up to 3 months. But a year is a bit prolonged. And in any case, you wouldn't give rig, even if if the dog was dead or escaped, rig would not be necessary. But maybe you could give the vaccine. If it's 1 year, that's a pretty long time. So these questions have come up many times on my email or WhatsApp, even after 2 or 3 years. So that really is not a good question.
Okay, thanks. So I think that's the questions we have for today. And because of the time, I think we can wrap it up. Thank you very much, Bernadette, Simba, and Nassim for this really, really interesting webinar. We hope to have a follow-up soon. And just to let everybody know, this has been recorded. The session is being recorded and will be made available really, really soon. We have our next webinar early July. The topic is still to be confirmed. And well, if there's nothing else from all you guys, I think we can wrap it up and say thank you again. Alexander, I don't know if there's anything from your side.
Thank you very much. No, I think you summarized it well. Bernadette, if you have anything you would like to add, or anyone else?
Should you have any questions following this webinar, please do reach out to me, and I will, get the best person to provide the questions. We've already put the resources in the question and answer. We will put those on the website as well. So just to let you know, you're not alone. If you have questions, do reach out to us.
Thank you very much, everybody. See you soon. And it was a real pleasure to be able to be in this webinar with you.
Thank
Thanks.
you.
Thanks a lot, everyone. Have a very nice rest of the day. Bye.
Thank you.
Thank you, Nassim and Simba, Christoph, Alexander, Mario. Nice meeting you.
Thank you.
You
Bye-bye.
too.
Thank you.
Thanks.